The management of acute hepatitis C infection in the HIV-infected patient is a very interesting problem. Usually what we do see is that HCV is acquired first, and this is usually in the setting of injection drug use, and then HIV follows later. But when we see an HIV-infected patient acquiring HCV, it's usually through sexual transmission, as has been described in men who have sex with men in certain outbreaks. In this case, any evidence or indication that the patient is already immunocompromised certainly could lead to a decreased chance of spontaneous clearance of hepatitis C. So that is something we have to think about in terms of our management. In acute infection, acute HCV infection that is, we usually see at first low levels of viremia. Sometimes we see viral load fluctuations greater than a log. And it's important to follow these things over time because if we check HCV RNA, I usually do it baseline, monthly, we might see a certain minority of patients, and it's a substantial minority, who might clear on their own. And we want to give them that chance because if they do, we don't have to expose them to the toxicities of interferon or ribavirin therapy. However, we also don't want to wait too long because if the patient develops persistent infection and then if viremia ramps up, then we lessen their chance of viral eradication. So it's a delicate balance of following them closely, allowing them to clear, and if they don't, to dive in and treat them. So what I usually do is I follow monthly hep C RNAs over about an 8 to 12 week period, and then by around 12 weeks make a decision if they're still persisting or if viremia is ramping up to offer them pegylated interferon plus ribavirin. The data are unclear actually as to whether ribavirin is truly indicated, but ribavirin does decrease the risk of relapse or viral breakthrough, so I do favor giving dual therapy to the co-infected patient. And I'll treat them for about 24 weeks as long as they rapidly clear in 4 weeks. And that usually is the case if you treat early on. The issue about when to give them ART if they're not on ART can be somewhat complicated if the patient has elevated liver function tests that are sky high. And sometimes treating the hepatitis C infection leads to biochemical normalization that will then allow initiation of HAART, and you certainly want to do that.